In my career, I have performed over 2,000 open heart procedures, enabling me to physically hold and examine the human heart, feeling the palpable distinction between tissue operating optimally and tissue that is succumbing to a silent, escalating systemic failure. For years, some of the most profound instances of cardiac damage I observed on that operating table were not traceable to lifestyle factors like a poor diet, substance use, or heredity. Instead, the deterioration was directly attributable to prescribed pharmaceuticals, medications issued with the utmost good intentions, yet which were covertly working in direct opposition to cardiac well-being. I am Dr. Jiang Xueqin, a cardiothoracic surgeon with a quarter-century dedicated to interventions where surgery became the final recourse. Today I address 5 specific medication categories taken daily by millions over 60, details that a standard 7-minute clinical consultation almost invariably overlooks. My intent is not to incite alarm, but to equip you with the necessary data points to forge a more comprehensive and productive dialogue with your prescribing physician. Beyond 60, the body's methods for processing pharmaceuticals fundamentally change. Renal filtration slows down. Hepatic drug metabolism capacity diminishes. The typical American senior manages 4 to 5 distinct prescription drugs concurrently. Some manage 8 or more. While each medication receives individual scrutiny and approval, the clinical ramifications of combining 3 or 4 of these agents within an aging, less resilient system rarely receives adequate preemptive investigation. I want to introduce you to an individual I will refer to as Clarence. At 74, he was a retired electrician, methodical, prudent, and adhering rigorously to recommended health guidelines, including 2 miles of walking daily and meticulous food choices. He entered my orbit following his second significant cardiac event within an 18-month span. He wasn't merely tired, he suffered from profound, pervasive exhaustion, the deep, unrelenting fatigue resistant to even full night's rest. Furthermore, he endured agonizing muscle cramping that invariably struck at 3 a.m., accompanied by a measurable decline in his cognitive sharpness, all actions which significantly frightened him. Multiple practitioners reached the same conclusion. Clarence, you are 74. This decline is age-appropriate. This was his baseline for 2 years. Upon reviewing his complete medication dossier, every agent, every dosage, I pinpointed the cascading issue within 5 minutes. It wasn't one isolated drug interaction, but a triad of concurrent pharmacological effects exerting pressure for 2 years straight. We must circle back to Clarence, as the resolution of his narrative encapsulates the core justification for this entire presentation. Here are the 5 problematic classes of medication. Statins. If you are over 65 in the United States, statistically, you face about a 1 in 3 chance of taking one of these: atorvastatin, rosuvastatin, simvastatin. The compound names vary, but the mechanism remains constant. Statins undoubtedly save lives when treating established cardiovascular disease. The clinical evidence supporting this is undeniable, and I have personally prescribed them thousands of times with conviction. However, a critical consequence is detailed in the lesser-read literature. Statins work by inhibiting the mevalonate pathway. Crucially, this pathway is responsible for synthesizing not just cholesterol, but also coenzyme Q10. CoQ10. This distinction changes the risk calculus profoundly. CoQ10 is the essential fuel that powers the individual heart muscle cells. Without adequate levels, the cardiac engine runs roughly, eventually degrading performance. Decades of research, notably meta-analyses initiated around 2005, consistently show statins reduce systemic CoQ10 concentrations by 30 to 50%, a substantial depletion in the very organ most dependent upon it. The manifestation in some patients includes debilitating fatigue unresponsive to rest, generalized muscular weakness, mental cloudiness, and a quantifiable decrease in measurable cardiac output. Clarence had been on a high-dose statin for 2 full years, essentially running his heart on a diminished fuel supply. What should incite genuine frustration is that CoQ10 level testing is not automatically integrated into standard guidelines. Since CoQ10 lacks Patent exclusivity. There is little financial impetus within the system to mandate this simple check alongside standard protocols. The corrective measure involves introducing 100 to 200 mg of CoQ10 daily. The Q-Symbio trial demonstrated clinically significant improvements in heart failure patients who added this supplementation. Should I be supplementing with CoQ10 concurrent with my statin therapy? Write that precise question down for your upcoming review. Pill 2. The unexpected adversary. This medication often surprises patients because it does not register as a primary cardiac agent in the public perception. We refer to the non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, naproxen, diclofenac, cheap, readily accessible over-the-counter, present in nearly every home medicine cabinet. The prevailing, though flawed, assumption is inflammation is detrimental to the heart. NSAIDs combat inflammation. Therefore, they are benign at worst. This logic is catastrophically inverted. NSAIDs exert their action by inhibiting COX enzymes, but crucially, they inhibit COX-2, an enzyme responsible for generating prostacyclin. Prostacyclin is the natural protector of the blood vessels. It keeps arterial linings flexible and actively discourages the formation of dangerous, unwanted clots. By blocking COX-2, you strip away this essential vascular defense. Concurrently, consistent NSAID usage elevates baseline blood pressure by an average of 3 to 5 mmHg. While this figure seems minor in isolation, layered upon already stiffened arteries in an individual over 60, this chronic low-level increase significantly escalates the lifetime risk of stroke through sheer persistent mechanical strain. The FDA formally reinforced this hazard with a black box warning on all NSAIDs in 2015, explicitly citing increased risk of heart attack and stroke. Clarence was consuming daily ibuprofen for 2 years, a fact his various providers were aware of, yet no one flagged the cardiac risk potential inherent in that chronic use. For persistent musculoskeletal pain, discuss the use of topical NSAID gels with your doctor. These provide equivalent local anti-inflammatory relief with reported systemic absorption reduced by 90%. For general background inflammation, scientific literature increasingly supports curcumin paired with piperine or high-dose omega-3 fatty acids, EPA and DHA, which boast data showing significant reduction up to 25% in trials like Reduce It in major adverse cardiac events compared to many low-dose treatments. You should never cease a prescribed anti-inflammatory without your physician's direct input. The objective is facilitating a better discussion leading to better management. Pill 3, the gatekeeper medication failure. This is a compound that took the medical establishment an embarrassingly long period to fully correlate with systemic damage because it does not physically resemble a cardiovascular medication. Many patients buy it over the counter or take it routinely with their morning coffee, never suspecting its hidden systemic consequences. These are the proton pump inhibitors, PPIs, omeprazole, pantoprazole, lansoprazole. Approximately 15% of the adult U.S. population relies on them, with many patients on multi-year or multi-decade regimens. Here is the overlooked mechanism. Stomach acid is not solely a nuisance to be eliminated. It functions as a crucial gatekeeper required for the adequate absorption of vitamin B12. Chronic suppression of acid production via PPIs consequently blocks B12 absorption, sometimes near totally. Why is B12 critical to a cardiac surgeon? Because B12 is indispensable for metabolizing the amino acid homocysteine. Elevated homocysteine levels directly correlate with measurable damage to the interior lining of arteries. It is an independent risk factor for cardiac events, with some studies equating its risk profile to that of moderately elevated cholesterol, yet it remains conspicuously absent from routine cardiovascular panels. A 2013 study in Gut revealed that long-term PPI users exhibited B12 levels 30% lower than their peers, a deficit exacerbated by age-related decline in intrinsic factor production. The dual insult means an elderly patient faces a drug-induced deficiency layered upon a natural age-related scarcity. Symptoms: unrelenting fatigue, creeping memory impairment, gradual onset of peripheral tingling, develop so slowly they are often mistaken for simple aging. Prolonged severe deficiency can cause irreversible neurological damage, initiated by a heartburn drug drug taken for 10 years because the monitoring protocol neglected annual B12 checks. Furthermore, PPIs actively deplete magnesium, an essential mineral involved in over 300 enzymatic functions, crucially regulating the electrical stability of the heart. Magnesium deficiency is intrinsically linked to arrhythmias and the severe muscle cramping Clarence experienced at 3 a.m. Clarence's labs showed critically low B12 and magnesium levels at the low end of the normal spectrum, technically acceptable values, prompting no remedial action from any provider. If you rely on PPIs long-term, your required intervention is to request a baseline test for both B12 and magnesium levels. To address potential deficiency safely, one might utilize sublingual methylcobalamin, 1000 mcg, to bypass the acid-dependent absorption system entirely, and a highly bioavailable form of magnesium, such as magnesium glycinate, 400 mg daily. Importantly, do not cease a PPI abruptly, as it causes a rebound hypersecretion of acid. Tapering must be gradual, overseen by a physician. Thus, statins depleting CoQ10, NSAIDs stripping vascular protection, and PPIs blocking B12 and magnesium absorption, all three factors present simultaneously in Clarence's case for 2 years without a single provider aggregating the toxic load. Pill 4 involves a necessary preventative agent that simultaneously appears to facilitate damage I have personally witnessed on the operating table. And Pill 5, that one is a medication I reflexively recommended myself for over a decade, which subsequent data has demonstrated may have been fundamentally counterproductive. I will reveal precisely what I told my own patients once I fully comprehended the compelling clinical evidence, a conversation that was personally uncomfortable. Pill 4 concerns warfarin. Utilized since the 1950s, it remains a cornerstone anticoagulant for managing conditions like atrial fibrillation, DVT, and mechanical heart valves, and its efficacy in preventing devastating clots is undeniable. I do not dispute its necessity where indicated. However, the details absent from the 7-minute appointment relate to its mode of action. Warfarin operates by antagonizing vitamin K. Critically, it cannot distinguish between the two vital forms of vitamin K. Vitamin K2 has the sole role of activating proteins that actively shunt circulating calcium away from arterial walls and direct it into bone tissue. When K2 function is suppressed by warfarin, calcium deposition into the arterial lining proceeds unimpeded, leading to vessel calcification and stiffening, similar to mineral buildup inside plumbing lines. As a cardiac surgeon, I have visually documented the consequences of heavily calcified coronary arteries, a condition that dramatically complicates both surgical access and long-term patient recovery. A 2019 study in the Journal of the American Heart Association indicated that long-term warfarin users demonstrated significantly accelerated coronary calcium buildup compared to matched patients on newer oral anticoagulants, provided their doctors were also proactively managing cardiovascular health. Does this imply a patient should abruptly discard warfarin? Absolutely not. Untreated AFib carries an annualized stroke risk up to 5%, a hazard too high to ignore. However, this finding necessitates 2 critical queries for your next consult. First, considering current options, is warfarin still the optimal anticoagulant choice for me? Newer agents like apixaban or rivaroxaban do not exhibit this pronounced interference with the K2 calcium deposition mechanism. Second, has anyone ordered a non-invasive coronary artery calcium CIC score for me? This simple low radiation CT scan provides an objective measure of your current arterial hardening status and is criminally underutilized as a cardiovascular risk stratification tool. Pill 5 is perhaps the most difficult to discuss, not because the science is complex, but because for 15 years, I dispensed this recommendation confidently and according to new data, likely incorrectly. This concerns calcium supplements. If you are a female patient over 60, the likelihood is high that at least one physician has advised a daily intake, typically 1-200 mg to support bone density. This feels intuitive. It's a standard piece of health counsel that demands little scrutiny. However, a landmark 2010 meta-analysis in the British Medical Journal analyzing 15 randomized controlled trials involving nearly 12,000 subjects, presented a staggering finding. Supplemental calcium intake without adequate cofactor support, specifically K2 and vitamin D3, was associated with a 30% increased risk of adverse cardiovascular events. The calcium paradox: a person diligently takes a pill designed to fortify their skeletal structure, but if the excess calcium is unmanaged, it is deposited into the soft tissues, notably the arterial walls. The very same stiffening seen with warfarin use. A sudden high-dose bolus of supplementally delivered calcium floods the system, and without K2 directing it towards the skeleton, a portion settles into the arteries. Reversing a 20-year-old universal guideline recommended to tens of millions is bureaucratically challenging. It is simpler to issue a minor update than to formally state, "We disseminated an incomplete strategy." When I encountered that data, I reflected on every elderly female patient to whom I had confidently issued that routine order. My responsibility shifted instantly. The obligation was no longer to practice what I was taught, but to ensure the next patient received the full scientific context. If you are supplementing, do not discontinue abruptly, especially with documented osteoporosis. Instead, initiate this conversation. Should I ensure my calcium intake is co-supplemented with K2 and D3? The evidence strongly supports combining calcium with K2, specifically MK7 form 100 mcg daily, and vitamin D3, a minimum of 2,000 IU daily, or more based on tested blood levels. Furthermore, always prioritize dietary sources first. Dairy, leafy greens, or small fish consumed bone-in, using supplements only to fill validated nutritional gaps. I need to step back from this inventory of necessary precautions. The majority of this discussion focused on the mechanisms through which common medical approaches might inadvertently impede cardiovascular health post-60, but effective heart defense involves providing the body with proactive, scientifically sound support structures that often circumvent the issues we've discussed. High-dose omega-3 fatty acids, 2,3G daily of EPA-DHA, remain exceptional for lowering triglycerides and actively calming systemic inflammation, preserving vascular flexibility. Magnesium, 400 milliliters, specifically in a highly absorbable chelated form like glycinate, not cheap oxide, supports cardiac rhythm regulation and lowers systemic tension. Curcumin with piperine shows tangible efficacy against the chronic background arterial inflammation that silent NSAID use can worsen. Nattokinase, derived from fermented soybeans, exhibits compelling support for healthy blood flow by moderating fibrin levels that contribute to clot tendency. And aged garlic extract demonstrates proven benefits in softening arteries and modestly lowering blood pressure. None of these are miracles, and none should supplant prescribed therapies where clinically necessary, but they represent the support nutrients the body needs to operate optimally when its internal defenses are compromised. Let us return to Clarence. After our intensive review of his entire regimen, every agent, every dosage, every known interaction, I personally conferred with his managing cardiologist and primary physician. We collectively drafted a layered cooperative plan. CoQ10 supplementation was initiated. His critically depleted B12 required immediate sublingual therapy, bypassing stomach acid dependency. Chelated magnesium was added. His daily ibuprofen was converted to a topical diclofenac gel, retaining the anti-inflammatory effect while reducing systemic exposure by an estimated 90%. His doctor also facilitated a slow, careful taper off the PPI, introducing K2 and D3 to optimize his existing calcium intake. We weren't adding new drugs, we were addressing the depletion caused by the existing ones. 6 months later, Clarence's cardiologist reported he had been able to reduce Clarence's antihypertensive regimen from 4 drugs down to 2. His inflammatory markers showed significant positive shifts, and his pressure was consistently controlled. He looked palpably years younger. His closing remark to me, echoed by his grateful family, was profoundly simple. Why did nobody articulate this connection sooner? This sentiment, the gap between scientific knowledge and routine patient counseling, is precisely the motivation for this entire communication. You now hold the detailed information. The question for you is one of immediate execution. If this knowledge resonated with you, particularly if you or a loved one is navigating a multi-medication protocol, share this with them. They need to frame their next doctor's appointment differently. Finally, I reassert the essential boundary. This constitutes educational context based on current research and my professional experience. It is not a substitute for direct medical orders. Engage your physician armed with this complete understanding. Collaborate with them to synthesize the safest, most effective path forward. Your heart has been your steadfast partner for decades. It merits your full, informed attention now.